75-year-old female, known case of coronary artery disease, undergone a CABG surgery in year 2013, hypertensive, hyperlipidemic. She presented with the dyspnea and chest pain on and off for 4 months duration, and symptoms also she used to get at time rust, for which she has undergone angiography 4 months ago. Angiography shows the left main coronary artery has a 99%, and it is a calcified lesion with a TIMI grade flow 1. Grafts to limma to LAD patent, and SVG graft to right PDA was patent. She was advised to PTCA, but she refused at the time. Investigations are normal, but the only thing is an abnormality is the lipids are under control, not controlled. ECG shows STT changes in the inferior lateral leads. 2D echo EF was normal, and mild AR, and there is no ASMS, and mild MR. And wall motion abnormality was present. This was the ECG changes. This time presentation was actually chest pain. There was subtle changes of there in ECG, and we took an coronary angiogram. We are not able to see that LM is totally occluded, and it is highly calcified, and even multiple views we took, there is no flow in the LM. Then I decided, anyway, it is explain the risk to the patient since it is a protected left main. Then using a fielder XTR wire to cross the it went, and I didn't know where it is going wire actually, because I am not able to see, there is no forward flow. Then what I did is, and I took a help of the micro catheter, and jammed the micro catheter, I injected, and I could able to see that L6 is a large vessel with a ramus, and that is also ramus or a high OM you can call it, is an also big size vessel, and it's flowing. Then since microcatheter is already there, took in a rota wire, and rota wire went into the directed to the high OM. Then I could able to take a 1.5, 1.25 and 1.5 mm bar to ablate the lesion. When ablating a lesion, suddenly the lesion gave away. The bar went directly into the ramus, this high OM. And which must have caused some damage. Later on that was revealed. Then I dilated with a balloon 2.5 mm into 2, and initially started with the 2 mm and 2.5. Then I could able to establish the flows in the circumflex and the IOM. The distal circumflex was stented with 2.5 into 33 mm Alpine stent. On the proximal was used to 18 mm stent, and post dilated with 3.5 into Tola NC balloon at a high pressure. And there was, I could able to see that there was flow in the high OM. Then it was looking small. I decided that not to do anything, we'll leave it at this stage. And then 1 hour later, patient again had a chest pain, and with the severe STT changes, and associated with hypotension almost, and not able. Then again went directly into the lab. It says that the IOM is totally closed. The circle was flowing very well, and which was wired with fielder FC wire, and opened up and did in a stop stenting, because since his already stent is there, the only way I can do is an size variation is there, is the stop stenting I could able to do. And after stenting the proximal segment, I could able to see there was a small dissection distal to that must have closed the burr on the previous wire. Take one more stent distally and stented that. I think that was this inferior. And the final result was excellent. And take home message is rotablation is only the choice for these kind of lesions. I don't think orbital atherectomy also can be possible to do. And crossing the wire with the rotawire in this situ is very difficult. So sometimes what it has been explained is you jam the microcatheter and take your rotawire And upfront root ablation with a small burr and a gradual upsizing will modify the lesion. It helps to adequately dilate the superficial calcium and helps in efficient delivery of the stents and balloons and optimization of the lesion with a good outcome.
So a great case, as always. We all know, last but not the least. You are such an accomplished operator. Why did you have to struggle to go integrate? I mean, you were guessing where your wire was. You had two conduits. You could have used the conduit to the left system.
There was no actually collateral flow into the system.
No, but you had, you said there was a protected left main.
It was a protected left main.
So you
But
had a
the
conduit into the left system.
So it was not, the LAD, mid LAD was totally occluded. There was no way I can go retrogradely through the...
And you had nothing into the circumflex.
Nothing into the circumflex. Because circumflex was normal at the time when she underwent a bypass surgery. There was no graft was done. And RCA then highly impossible. There was no collaterals to the circles also. There is a... since mid LAD, see, even if you do the this one injection, after opening, there is no flow in the LAD at all.
I thought that was competitive flow, because if you see the way it is going forward
No,
and backwards.
the competitive flow is only to the diagonal, proximal diagonal. Not in the LAD.
It looks like the. Anyway,
Not in LAD.
I'm sure you must be right.
Not in LAD. That was diagonal was there, that was going on. And even if retrograde also, it is not that easy to go through the conduit and go and...
You should know where you are. If nothing else, that wire serves as a landmark for you to see where you're going, because I would be kind of scared to rotablate when you don't know where you're going.
Correct, that's
you,
true.
You don't know where your wire is,
Yeah.
and now you are decided to rotablate something.
Yes, since I saw the distal vessels after the microcatheter injection, then I was confident about, but the wire I could not able to negotiate into the circ because of it is in a bend. So it went into the high OM. Then I decided, okay, since I have to, then since
That it's enough
Yes.
is enough of interventions and complications and horror.
Since it's only I have to burr the left main, I decided to carefully do it. But suddenly, the moment it gave away calcium, the burr jumped into the OM that caused the dissection.
In terms of C2 PCI, we tell them that if you want to finish the case, you do a tip injection. So if you want to finish your case, you do a tip injection. Because if you're truly finished, if you're not
Not with the full limit, you're still finished.
Yes. Thank you. Thank you very much.